One of the most fascinating areas of basic and clinical research in recent years has been the data coming out about the potential anti-tumor efficacy of bone-targeted treatments. We have, at least in some settings, been able to demonstrate that aminobisphosphonates would not only stabilize bone in early cancer setting, but also act against the tumor in terms of the ability of reducing relapse. This is very exciting, although I have to say we are not in a position to perfectly explain how this works, particularly because we see in studies of adjuvant bisphosphonates that not only bone metastases are reduced, but also relapse at other sites outside bone. Very obviously, with such an effective drug with denosumab available, we are now eager to investigate whether with the more efficacious drug this may also translate into the same effect. We have seen some data in the prostate cancer setting, recently published, that there is an improvement in outcome parameters. In addition to this, there are two large adjuvant trials in early breast cancer. One is ABCSG18, which compares 6-monthly denosumab, the bone protection dose, where it was placebo in the early breast cancer setting. The other one is DCARE, which uses a slightly more intensified schedule of adjuvant denosumab. Both trials are about to finalize their recruitment. However, it will be a couple of more years until we can expect first results. Difference between ABCSG18 and DCARE is that ABCSG18 has fracture prevention as primary endpoint, and the oncology outcome parameters are secondary endpoints. This is kind of logical because the dose of denosumab used is the dose used for treatment-induced bone loss as well as osteoporosis, 60 mg twice yearly. In DCARE, bone metastasis-free survival is the most important endpoint, and also the intensity and frequency scheduling of denosumab is more intense. It starts with monthly DMAP and is then tapering down to 3 monthly and eventually 6 monthly over an adjuvant treatment duration of 5 years. So the trials are different, but they are going to give us insight also in whether there would be differential results. I think that the whole breast cancer community, for that matter, is very eager to hear the first results of these two trials. With respect to the potential adjuvant benefit of these drugs, obviously one could speculate that a complete blockade of the vicious cycle in bone would be more effective. Personally, but there is my bias of ABCSG18, this can be true, but it can also not be true. Experience from the bisphosphonates showed that the bone protection dose, low dose, limited frequency, is at least as effective because obviously when we target micrometastases, and this is what we do in the adjuvant setting, it may not be necessary to really stop the bone turnover as we do with the high dose, which is very effective for treating bony metastases. In order to prevent micrometastases from growing in the bone marrow, but not necessarily in bony metastases, it might be also effective just to do this on a low dose, which would obviously have advantages for patients in terms of tolerability, logistical burden. Don't forget, these patients are healthy and can hope to be cured from their cancer. So this is quite a different setting from the treatment of metastatic disease we discussed previously.